I had an SRPE patient today.
Dr.
really?
Goldstein, we're being recorded. Let's not discuss those. So I can't see how many people are on, but I hope that we have a nice, vibrant group today. My name is Sue Goldstein. I'm a member of the SMSNA Educational Projects Committee, and that's why I'm here as your moderator. I'm an ASEC certified sexuality educator and a certified clinical researcher. So a lot of people think when I do work that I think out of the box. But since my background is very different than that of most of you watching this, it's not that I think out of the box, it's that my box is very different than your box. But today I'm going to challenge you. We're going to show you ways that you can think about, that you yourself can think out of the box. I'm sure many of you have had urologic problems that you treat in your traditional manner that just don't resolve. And so today we're going to give you some tools so that you can think out of the box and perhaps help some of those patients. In full disclosure, I'm going to introduce all of the speakers. However, Dr. Rubin had a severe reaction to her COVID booster, and so she's provided her slides, but Dr. Goldstein will be giving them. Also, Dr. Chol Kim wound up with an extra case in the OR. If he gets out in time, he'll give his slides. If not, we all of us on this webinar work very closely with Dr. Kim. So Dr. Goldstein will give his slides as well. So I do apologize that 2 of our 4 speakers are missing, but we do have the content that they all provided, and that's the most important thing. So I'm going to introduce both Dr. Rubin and Dr. Kim, along with Dr. Kamazarek and Dr. Goldstein, because it is their content, and they have provided that. Dr. Rachel Rubin is providing the introduction to the case we're discussing today. She is a board-certified urologist and sexual medicine specialist. She is an assistant clinical professor of urology at Georgetown University and has her private practice in Rockland, Maryland. Dr. Erwin Goldstein will explain how he would work up this case. He is a board-certified urologist who practices sexual medicine exclusively. He is director of sexual medicine at Alvarado Hospital and practices at San Diego Sexual Medicine. Dr. Barry Kamazarek is going to talk to us about why we do what we do. He is a distinguished professor of psychology, a Rutgers University Board of Governors Distinguished Service Professor, and an adjunct professor of radiology at Rutgers University. His work with MRI has changed the way urologists and sexual medicine providers look at various urologic and sexual medicine disorders. And finally, Dr. Chol Kim is a double-boarded certified minimally invasive spine surgeon, founder of the Minimally Invasive Spine Centers of Excellence, and founder and former president of the Society for Minimally Invasive Spine Surgery. He's an expert in the field of computer-assisted minimally invasive spine surgery and a world leader in laser endoscopic spine surgery. And now that I've bored you all with the introductions, I'm going to turn this over to Dr. Goldstein. He'll share the screen.
Thank you very much, Sue. Thank you, Barry. Just so that you all know, I was working with Barry this morning at some god-awful hour to show how much we work together a lot. This is Rachel Rubin's talk. Rachel Rubin is a former fellow of mine and has really become a world leader in her own right. She has a practice in Washington, D.C., and it includes very often patients who have various disorders, pains, dysesthesias that are not classically in the region of the genital pelvic area. And the purpose of this seminar is to basically allow you to think of pain in the genital pelvic area. This is a person with penile pain, but you could have scrotal pain, you could have perineal pain, you can have perianal pain, you can have suprapubic pain, you can have epididymal pain, testicular pain, and the pain is actually not coming from the genital pelvic organ. And that's kind of hard to envision. But the simplest way to think of this is sciatica, lower extremity sciatica. Patient has burning, shooting pain going down the leg. And there's nothing wrong with the leg in any way, sense, or form. Everybody understands the lower extremity sciatica, the pathophysiologic location of the trigger is actually in the lumbosacral area as a some radiculopathy that's causing this situation. So the the crux of this matter, can you get, as urologists and sexual medicine interested people, your head around the fact that you could have a genital pelvic symptom, a patient in your office with unwanted genital pelvic pain, in this case, again, penile pain, but it's not coming from the penis. It's coming from some region closer to the central nervous system. So that's the idea of this seminar. We see tons of these patients. I just got a referral from a doctor in Virginia who has a patient with burning of his penis, just unrelenting burning of the penis. And he was seen by multiple doctors, Mayo Clinic, blah, blah, blah. And he read an AUA news column on the same topic, where in fact, we talked about penile pain coming as the equivalent of lower extremity sciatica. He had penile sciatica. And we ended up curing that patient with work in the cauda equina. So as per Rachel Rubin, this case has been published. It's in the journal Sexual Medicine, and the title is a novel collaborative protocol. And you'll see the author here, Barry Kamazarek, and myself and Rachel Rubin, Sue, and Chol Kim. So the entire staff speaking today is actually a member of this group. So this is a kid, 14 years old, who now became pubertal and started getting nocturnal erections. And he would wake up with very painful erections during the nocturnal event. And then as he started to masturbate, as he started to achieve erection and the erection was of good quality, he would get severe penile pain that was so intense that it prevented him from masturbating. And try and look at a 14-year-old kid, or try to think of yourself, if you're male, as a 14-year-old boy unable to masturbate because your penis hurts so much. And he perceived the pain as in the penile shaft, not the glands or surrounding genitalia. And basically, he eventually told his parents. It took a whole year till he told his parents, but the parents took him from doctor to doctor to doctor. The patient lives in British Columbia, and he ended up in Vancouver. And then in Vancouver, he met with a colleague who eventually sent him to San Diego, where we examined him. But he had, I think it was 5 or 6 or 7 years before he came to San Diego. And he was at the end of his rope, and he was just convinced he would never have a relationship again. And his symptoms were a dysesthesia of the penis, basically, but associated with arousal. And he also had a urinary frequency, and he had restless legs. I just want to point out that restless legs is actually a symptom of sciatica. So if in fact you look at his symptoms, you can think of painful erections as involving either the pudendal nerve or the visceral afferent pelvic nerve, and restless legs, the sciatic nerve. And if you think of where could sciatic nerve, where could pudendal nerve, and where could pelvic nerve all meet, the answer is it's probably in a region that is not in the periphery, but it's in the lower part of the central nervous system. Now, he does recall falling down the stairs at a very young age, 8 months, and he straddled the metal bar of a monkey bar at age 7 years of age. So there is some sort of coccyx, trauma to the lower spinal cord area. And again, this poor guy was seen by countless doctors from all over British Columbia, and then eventually came down to San Diego. He did not have Peyronie's disease as the cause. There was no evidence of local pathology in the genital pelvic area that was causing this. He had pudendal nerve blocks. He had all kinds of tests, and all of them were negative. And one specialist said, no answers, no suggestions, and no tests that could be done. So among all the injections he had and treatments he had, he was on multiple medications to deal with the dysesthesia, from Botox to pregabalin to diazepam, nortriptyline, so atypical antidepressants, dorsal nerve blocks, pudendal nerve blocks. He had Alcock's canal injections of the pudendal nerve. Now, he did have a finding on a pelvic MRI that was read as incidental. Remember this word, incidental Tarlov cyst. The doctors read it, but said, we see this all the time. It doesn't mean anything. I want you to keep that in the back of your mind, incidental Tarlov cyst. This is, I guess Rachel is supposed to say what happened to him after surgery. So why don't we stop here and just stop that part of the talk. And now I'm going to follow with my own screen, which is going to take us into some more information on this. So in summer, we have a kid with unwanted penile pain during arousal that prevents him from being sexual and completely screws up his intimate and pubertal teenage years. And doctors are not helping him. And there's an incidental finding in the spinal cord area. Okay, so I have 10 minutes. I'm going to take you through how I would evaluate, and it's not how I would, it's in fact how we did evaluate. So again, this 14-year-old kid had extreme penile pain within seconds of sexual arousal through masturbation. I don't know what you think of, but you may think of, he broke his penis, or he landed on his penis on a bar, or he had Peyronie's disease, but the fact of the matter, he didn't have anything. And I said he was in multiple years of treatment. It was 7 years. He was 21 when he finally came to us in San Diego. So I'm going to take you through the way to think of this so that you forever and ever can follow this. So he has a genital pelvic dysesthesia. So he has unusual, unwanted pain in the genital pelvic area. He had penile erections that really hurt during an arousal response. So in the genital pelvic area, there are in the brain 3 different nerves that send information to the genital pelvic area that's seen and processed in the somatosensory cortex. Here's the somatosensory cortex. Here's homunculus, and here is where the genital pelvic area is identified and processed. That's called the paracentral lobule. So the paracentral lobule receives information from pelvic, pudendal, and sciatic. And if you go back to his history, he had the restless leg, he had the pain in the penis, and he had pain with stretching of the penis. That's classically a visceral afferent nerve issue. So he had persistent unwanted genital pelvic area. He had extreme pain within seconds of arousal. Okay. Now, if you look at what sends messages to this paracentral lobule in the somatosensory cortex, it's the pelvic, pudendal, and sciatic. Oh, no, sorry. Okay, so now they're full screen. Sorry. So the next thing is I've kept this sort of constant of the genital pelvic area and sacral nerve roots in comprising pelvic, pudendal, and sciatic. And I know Barry's going to go over this in greater detail. This is one of my favorite sort of schematics. You have the 3 nerves that comprise the information from the genital pelvic area that goes to the paracentral lobule. You have the green sciatic. Remember, he had restless leg. Pudendal nerve, which is the somatic sensory to the penis. There's no motor to the penis. There's motor to the pelvic floor. And the pelvic nerve, which is visceral afferent to the penis, it does the stretch. So if he gets a real strong erection, his penis will feel the stretch through the visceral afferent pelvic nerve. But in this case, it was dysfunctional because he had horrible pain with that. So if we say he had contributions from the 3 nerves, we say, okay, well, region 1 could be the penis, but he had sciatic nerve involvement, so that doesn't make sense. Region 2 is the pudendal nerve. He had multiple pudendal nerve blocks, that didn't help him. And it doesn't involve the sciatic nerve, but region 3 up here, which is in the cauda equina, where the sacral nerve roots come all together, and the sacral nerve roots comprise information from the sciatic, the pudendal, and the pelvic. What if we gave him a lesion in the cauda equina, which was this incidental thing they found on his pelvic MRI? So in order to put this all together in a logical, rational way, we developed a sort of a collaborative protocol. So we have a bunch of people with expertise. Barry is the one who constantly explains things to us and challenges us with logical, rational information that passes neurologically. We have been able to do testing of the genital pelvic area to give us different patterns that give us different locations. If it's region 1 or region 2, it has a certain pattern. Region 3 and region 4, which is the spinal cord, a certain pattern. And region 3, a specific pattern. Region 4 and 5, which is the brain and the upper spinal cord, gives us another pattern. And we get an MRI specifically, in this case, instead of a pelvic MRI, a specific sacral MRI, which will show the incidental lesion a little better. And then we do a numbing test. So we would inject into the caudal region, if it's in the sacral area of the pathology, which was on the incidental version of the pelvic MRI. And then we could say, okay, we have all the evidence. It's a sacroradiculopathy secondary to, let's say, the Tarlov cyst here. All we have to do is unravel the inflamed nerve from the Tarlov cyst and move on and cure this patient. So again, this is a patient who, during masturbation, every time he has severe penile pain, if you look at the paracentral lobule in him when he's having pain, you would see in an fMRI a huge intense amount of activity. This is the intensity scale, white being intense. This is someone who is just asked to touch their genital, and an fMRI would be this small red thing, low intensity, small volume. Now, there are many other people, just to broaden this outside of this one patient, sleep-related, painful or prolonged erections, unwanted persistent genital arousal in male, severe pain, electric shocks in the penis, burning, stabbing, swelling, achy, scrotal pain, unresponsive to countless therapies. They could all be due to pathology in the cauda equina. I just assure you that that's true. We see it all the time. And the best evidence we have is when we operate on the cauda equina and we relieve them of their problem. That is clear evidence of involvement. All right, this is the way to think of this stuff. You have stuff in the penis area, stuff in the pelvis area, stuff in the lowest part of the spinal cord, upper spinal cord, and region 5. This sort of construct of how to think of people with genital pelvic pain, or the persistent arousal version of genital dysesthesia, was described in a consensus paper that we did for ISSWISH, which is the study for women's sexual health, but it applies clearly to men. So here's the cauda equina. These are the Tarlov cysts that can be found in people with pathology in the cauda equina. And you can see in region 3, sacral Tarlov cyst is an excellent explanation. I have, just to honor Barry Komisarek, he in 2012, when I was editor of the Journal of Sexual Medicine, sent this paper in on Tarlov cyst causing PGAD. And I said, this is a little weird. Where is this coming from? I never even heard of this. And since 2012, now it's 2022, 10 years later, it's become a standard part of the understanding of this condition.
I think the expression is we've come a long way, baby.
Yeah, and we a lot more to do. So this is a vibration testing of the penis. So this would assess the somatic dorsal nerve, also the perineal nerve, depending on where we place this. Then we test for hot and cold, and this would be A beta. These are A delta and C fibers, hot and cold. The cold is the A delta fiber, sorry, and C fiber is cold, as hot. Oh, I'm saying that wrong. A beta is vibration, A delta is cold, and the hot is C fibers. And then we do a test of the integrity of the sacral dermatomes in the lower extremities, and that's important tests that we do. And then we do another test called the bubble cavernosus reflex. So this is vibration to and hot and cold of the penis. This is someone lying on the prone position. So we get the buttocks and thighs and calves, and we measure their integrity of when they perceive vibration compared to control. And this is lower extremity calf area. And then we do a reflex test. We tap the penis, we put electrodes in the external anal sphincter. We do a bubble cavernosus reflex. So if hot, cold, and vibration testing are abnormal, if the genital, non-genital sacral dermatomes are abnormal, so these tests, and if the reflex is abnormal, there's only one place that could be the pathology. That's in the cauda equina. Now, if it's going to be in the penis, then the sacral dermatome would be normal because there's nothing going on in the lower extremity. So that's distinguishing that. And if the bubble cavernosus reflex, which acts at the conus medullaris, the lowest part of the cauda equina, if you get normal BC reflex, then you're looking at above the conus medullaris or the brain. So these would be regions 4 and 5. Okay, so we have put together a triad of testing that sort of localizes in a non-invasive way. This was the pelvic MRI. This was a specific sacral MRI. Rachel showed you the specific sacral, and these are very obvious Tarlov cysts. And then the test that is done is called caudal epidural. So you find the spot around S4 where there's a notch, the sacral hiatus, and you put a needle in there with just lidocaine, and then just 1 ml of lidocaine, not much more, so it doesn't spread all over the lower central nervous system. And then you remove the needle, fluoroscopically identified the sacral hiatus, and then if that test shows, okay, now I can masturbate and I don't have pain, which is what happened to this patient. This really the first time in his life that he didn't have symptoms. Then we took him to surgery. We imbricated the Tarlov cyst, so it's no longer pressing on the pelvic nerve, which was really the underlying problem here. So in summary, a 14-year-old kid came to us with horrible pain. It took him 7 years to get to the concept that this wasn't in the pelvis or perineum. 7 years. We then followed him with neurogenital testing. We followed him with a caudal epidural, and we hypothesized his pain was due to Tarlov cyst-induced neuropathic irritation of sensory fibers that course within the pelvic nerve. Okay, when we numbed this, his pain went away, and we did surgical repair. We have, I think, 3-year follow-up now, and he's completely symptom-free. So really cool.
Dr. Goldstein, Dr. Elliott wanted us to make sure everyone knew that this young man, because there was nothing that appeared to be abnormal when he went to his urologist and his primary, that everybody assumed it was in his head. The psychiatrist was concerned he was suicidal. And we see that in a lot of these young people because based on the testing, there were no abnormalities because the testing that was done was traditional testing. We're thinking out of the box. Just a reminder, because many of you see people who look otherwise healthy, who are told it's all in your head, and clearly that's not always the case.
By the way, Dr. Elliott is a co-author on this paper because Dr. Elliott made the bold move of saying, gee, let's see if we could find out another view of this. So Dr. Elliott, thank you, and hello, how are you from San Diego? So I'm off now, and I'm going to give you Barry, okay? Thank you.
Thank you, Erwin. And Sue, it's really a great pleasure to work with you. I love continuing to work with you. It's a wonderful experience. I have some of the same slides that we really work together. So it's sort of off center. Can you?
Yeah, no, I haven't found it yet. Okay, there it is.
Get the. That's it. Okay. So yes, that what Erwin said is basically what I'm going to talk about. Maybe give some basic neurophysiology to account for it. So the first slide, please, Erwin. Again, it's this young man, so I won't go through this. You know how it was already described, but the reason why we think it's pelvic nerve, I will get to later on in the talk, toward the end of my my presentation. So the basic thing, it was so painful to this young guy that he said he only had 1 orgasm in his entire life. That was really impressive to me because he tried it once and it was so painful he never tried it again, and that's when he was 22 at the time. So. Next slide, please. So the Tarlov, what is the Tarlov cyst? The Tarlov cyst, Isidore Tarlov described this in 1930s, and yeah, it's like an aneurysm. It's a bulge. It's a bulge in the perineurium, and right at the point of the dorsal root ganglia, which are the sensory cells of the nerves. Of the sensory nerves, and they're filled with cerebrospinal fluid, and they're typically produced by a trauma, like a fall or a car accident, or a heavy lifting, or even childbirth. And very often there's a hereditary component, which is a weakness of connective tissue. So this tissue, it's the point where the dura ends and then just continues into the perineurium. And so it's susceptible to trauma. And so as Erwin pointed out, the picture on the right shows about the average size in relation to the rest of the pelvis of where the tarl lobes cysts are, and they're located just distal to the dorsal ganglion, with that weak spot in the covering, and that's what facilitates this kind of aneurysm. And as Erwin mentioned, during actual surgery, this is what the tarl lobe cyst looked like, and there are aberrant fibers within the cyst. And Chol describes it as ramen noodles, or a tangle of aberrant fibers, of sensory fibers within the sensory nerve root. And that's what produces the stimulation. But the next slide. But, we looked at, so we were looking for tarl lobe cysts, but in some cases of PGAD, we didn't see any tarl lobe cysts. But what we did see was herniated intervertebral discs. But the disc pushed on the yellow arrow indicates the cauda equina, where the nerve roots pass up from, they enter in the lower spine, in the case of pudendal and pelvic nerve at sacral 2, 3, and 4 levels, and they pass up in the cauda equina toward the first synapse in the spinal cord, which the spinal cord ends at about L2, the lower thoracic and the upper lumbar region. That's where the actual spinal cord ends, and that's where these nerve fibers, these nerve roots, synapse. So this is irritation of the fibers in passage, the sensory fibers in passage, and that's it can produce this. In this young man, he had an average of 8 spontaneous orgasms during which he ejaculated, and it was really terribly humiliating to him. He didn't like to go to work, so he had this herniated disc. And by giving a local epidural bupivacaine in a local anesthetic, he got relief for several hours, and the duration of the local anesthetic, and then the symptoms came back. So that was further evidence that, in addition to tarl lobe cysts, herniated disc can create symptoms. The next slide, please, Erwin. Here's another case of that we were seeing in cases of delayed ejaculation or anejaculation or anorgasmia. We also see a herniated disc, and I'll give our concept of how that can happen. In some cases, it's the irritation. In some cases, it's a numbness and lack of function, and it's all probably part of a natural history that can occur. So and it's also interesting that in multiple of these cases, the men say that they had hypersensitivity. They had genital hypersensitivity before they lost the function. So we think that there could be a so-called excitotoxic effect, where the excess stimulation eventually produces the lack of function. Next slide, please, Erwin. Next.
I'm trying.
Here are other cases of multiple herniated discs of anorgasmia. You see where the green arrows are. There can be multiple herniated discs, and these produce significant loss of function. And also on the right, another possibility is stenosis of the spinal canal, where it's actually pinched, and that's another kind of mechanical constriction of the fibers, pressure on the fibers as they pass through. You can see the fibers right above the orange arrow. You can see some individual groups of fibers. The next slide, please. This is no, go back. So this is an example of a of the herniated disc, and you see on the left this bright spot called the hyperintense zone or high intensity zone. That's diagnostic of an annular tear, and the diagram on the right shows an annular tear. The annulus is the tough ring around the intervertebral disc, and there's this gelatinous pulp. And when there's a tear in the annulus, the pulp can ooze out, and that can have, so the herniation could be a mechanical effect, and it can also be, since the pulposus, the gel inside the disc, it's a foreign chemical as far as the nerve roots go. So that can produce an actual inflammation. And Chol says that when he does the endoscopic surgery, he can see the inflammation of the nerves. So it's a combination of both, the mechanical and the chemical. And this is what Erwin was referring to. You know, we call it a genitopelvic sciatica, because where the nerve is pinched as it enters the spine, it's stimulating those the sensory nerve fibers that are normally activated by on the right shows a pinched nerve entering the spine, and the lower right, that, you know, that's the typical locations of sciatic pain in the leg and the foot. And so when the sciatic nerve is irritated at the pinch, it's a mechanical irritation. Activation of those fibers makes the person feel as if they're normally stimulated, where coming from the foot or the leg. So it's a referred sensation down to the normal sensory field, but the irritation is far from the actual source of the discomfort. So this is a showing that the pudendal and pelvic nerves on the left and right, on the left side, on the left panel, enter at sacral 2, 3, and 4, and you can see the labeling of the pudendal and pelvic nerve. I'll show another blow up of that in a little bit, in a few minutes. And on the right is the sciatic nerve, and you can see that there are branches that enter at sacral 2 and 3. So that's what Erwin was talking about. That it's a common. They all enter. All three of those nerves enter at the common sacral 2 and 3. The next slide. So this is the diagram that Erwin was showing, showing that all three nerves enter at sacral 2 and 3, and a disc, a herniated disc or an annular tear, can irritate those fibers at even far away from sacral 2 and 3, up higher, because it's irritating the fibers of passage. And you see that in addition to the sensory fields that Erwin was referring to, of the pudendal and pelvic nerves and sciatic nerves, there's also commonly urethral and bladder urgency and frequency and hypersensitivity, and also umbilical hypersensitivity and prostate. The umbilical sensitivity is something that's very, very strange to people. You know, they didn't even think of, they didn't even notice it until we asked them, and they say, oh yeah, my belly button is really irritated. It's very sensitive. So then, but it's the same pelvic nerve innervation. And the next slide shows the basis for that. no, go, yeah, that in the embryo in the lower left, the urogenital sinus is the common excretion from the gut and the bladder, and it excretes out through the urachus, which on the lower right, that feeds into the umbilical cord, which goes to the placenta, and that's how the fetus shows excretion. And in humans, in some cases, that urachus remains patent, and so urine can actually be expressed through the umbilicus in the adult, but it's because of that the urachus doesn't close off. But it's the same innervation, and that's why the umbilicus could be hypersensitive in relation to other pelvic nerve symptoms and even bladder symptoms. The next slide, please. So this is what I was saying, that how do we know that the pelvic nerve carries sensation from the internal part of the penis? So we did mapping of the genital sensory fields of the genitals in men and in women. And in men, what we did was in the upper right, we had the men squeeze the shaft of the penis, and then we had them squeeze the glands. And you see that the difference between the glands and the shaft is in the glands, there's no corpora cavernosa. So what we did was electronically subtract the activation we got when the men squeezed the glands from the activation that we got when they squeezed the shaft. And that gave us the difference of the corpora cavernosa. So and what we found is that the projection into the paracentral lobule, into the sensory cortex, was different when they squeezed the shaft versus when they she squeezed the glands. So when we subtracted the glands activity from the shaft activity, we got the activity coming from the corpora cavernosa. And because, as you can see in Netter's diagram, in that the pelvic, he shows a pelvic nerve, a sensory pelvic branch on the right, the label, you see the arrow pointing to that thin line. That's different from the pudendal nerve, which carries sensation from the skin. So in other words, the penis actually has two sensory pathways, one from the pudendal and one from the pelvic, which is the pelvic is what carries the sensation from the corpora cavernosa. And that could be why when he had the specifically erectile pain, it was, he could have erectile pain, but not pain when he just was masturbating. It was only when he got the erection that the pain came. So it wasn't due to the pudendal nerve. And that's evidence that it was due to the pelvic nerve input. So the final, my final slide is that this is the idea of the excitotoxicity. So we have this concept of the natural history where the low level intensity on low level irritation on the left, there's just genital awareness, uninvited, and it's not aversive. It's just they're just aware. The people, women and men, they're just aware of the sensation. And then with more intensity, they have the spontaneous orgasms, ejaculations, restless leg, which could be a reflex response of the sciatic nerve irritation. And then with more intensity, they have the pain. And that can continue either, it can either continue continuously or fluctuate over time, or it can become, the genitals can become numb. And that could be the muted orgasm. It could produce anorgasmia, anejaculation, anhedonia. And the idea is that it's an excitotoxic effect, damaging the nerve as a result of intense continuous stimulation. And so one of the main reasons we think so is that a lot of these people say that they had hypersensitivity early on, and it could be years earlier, and then it eventually became numb and hypofunctional. So, and the interesting thing is that when Chol does his surgery, in many cases, they recover the sensation. So it means that even after years of lack of function, the function can be restored. So it's very hopeful. So that's the basic idea, is that, as Erwin said, by having some kind of pathology, a radiculopathy, meaning the nerve root, that's the nerve, when it enters the spinal canal, becomes the nerve root, and the nerve roots make up the cauda equina, which then synapse in the spinal cord higher up. And so irritation of those nerve roots, and especially if they all go together, like in the case of the sciatic, pudendal, and pelvic, entering S2-3, form a bundle as they go up, and then they can be irritated in passage by these discs, or they can be irritated by the tarlo cyst lower down. And so both these pathologies, they're sacral or lumbosacral radiculopathy, meaning a pathology of the nerve roots, and that can be referred to the genitals and to the bladder and to the rectum. So that's our main conclusion.
Thank you.
Thank you, Dr. Komisarek. Dr. Goldstein's going to get up Dr. Kim's slides. In the meantime, if anyone has questions, you're welcome to put them in the Q&A. We'll hope we'll get to some at the very end. We'll see.
Okay, so I think historically, the way urologists got involved in the recognition that the pain in the penis, genital pelvic area could actually be coming from some other place. I just have to tell you, today I had a woman who had pain in her vestibule. She couldn't have intercourse, was just really sore. And she was in menopause age. So I said, oh, we'll come in. Well, it's obviously a hormonal thing. And we examined her vestibules, really sore and tender. We examined her hormones. They were really off. I said, oh, this is easy. We'll just give you hormones. And it didn't get better with hormones. And then we numbed the vestibule with a numbing agent, and her pain wouldn't go away. I said, okay, this is not working out like it's supposed to. Let's get an MRI. Let's do the neurogenital test. Of course, the MRI showed an annular tear. She was a weightlifter and an athlete and that kind of stuff. And we sent her for the injection of lidocaine at the level of the annular tear. And she did that in San Diego, which is great, because then as soon as she got out of the pain medicine specialist exam, she came in and I did Q-tip testing, which was sore, and I couldn't get rid of it with numbing, but they put the numbing now in the epidural space where the annular tear was. She was completely pain-free. It was the most beautiful thing I'd ever seen. She's now several weeks after her spine surgery, and she has no pain in the vestibule. So just another example. I just saw it today. I thought I'd share that. Now, we couldn't do anything. We wouldn't know how to advance if I didn't have this amazing spine surgeon who really is a pioneer in his own right, because when he does spine surgery, he does it through 5-millimeter tubes called endoscopes. And that's in itself an amazing thing. But he has taken on the concept that you can have back pain and you could have the need for spine surgery related to the back and sciatica, and that's everybody's world in the spine world. But we've convinced him that there are several patients with sexual medicine problems who have annular tears or tarlo cysts that are really caused by these sacral radiculopathies. And we've worked with him now for, God knows, almost 10 years. And we've developed paradigms, and we just submitted a paper to JSM on the endoscopic spine surgery and how it relieves people of this genital dysesthesia. Remarkable man. And I just hope that you could find in your local region, if you're interested in these diagnoses, to find somebody like Dr. Kim. Here are his consultancies. I don't really know about them, but those are the things we're going to talk about today. And the question is, when you get an MRI and you see something, how do you know it's treatable? By the way, I don't know, Sue, I'll just pick on you since I've nobody else to pick on today. If you have 100 people and you say, okay, let me get an MRI, and you say, oh my God, I found an annular tear there. What percentage of people have zero symptoms? They don't have any symptoms whatsoever, would have an annular tear. What do you think?
Most of them.
It's 25%. 25%. It's a really high number. But 25% of people will find to have an abnormal MRI, but symptom-free. And that means finding of an abnormal MRI has to really be, linked to a functional test and a functional anesthesia test before you take someone to the OR.
But that's why the MRI report that you get from the radiologist will either say there were no findings or incidental findings, because people don't think about sexual health or genital dysesthesias as being related to the spine. And so they never ask those questions. And that's why when we talk to patients, we say, send us the report, but send us the actual MRI. We want to actually look at it. So if you're thinking about expanding your practice to include this, you're going to need to have a spine surgeon who's willing to look at those MRIs and see, is there actually an annular tear? Because you are going to collect the symptoms. The patient is in your office because they have symptoms, and it'll be your job to try to figure out why do they have those symptoms.
Excellent points. So these are not treatable. So Barry, why is this not treatable? What's the reason?
It's normal.
It's normal.
There's no pathology.
No, there's no pathology. Do not treat somebody who has a normal MRI. All right, Barry, why are these not treatable?
The risks of treating it are greater than the potential benefit.
Yeah, I mean, this is a curved spine, kyphotic spine, and there's an annular tear, basically, or a herniated disc everywhere. It's just too much for taking on this project. So you can have somebody not treatable because he doesn't have an abnormal MRI, or he's a 2 abnormal MRI. And you want to do the treatable is the just right MRI. So you can see here, there's a Tarlov cyst. This is that dural ectasia. If you Barry called it the aneurysm of the dura, you can see that. And remember, the sacral nerve roots pass right around this, so they could be twisted, ramen noodly things, causing the sacroradicula, the irritation of the sacral nerve root. And this is another treatable lesion. This is a herniation that's stenosing or mechanically compressing. You got to worry about something like Cauda-Equina syndrome. I'm sure you've heard of that. If you really compress this, you can cause Cauda-Equina syndrome. You can see, if you look at the dura should be flat across. You can see that there's disc material pushing down on this individual. And those are the arrows showing the herniated discs. And then Barry talked about the HIZ, the high intensity zone. This is basically extruded nucleus pulposus in the epidural space. And you can see it's pressing in on the dura, and you get not necessarily a mechanical thing, because it's not that much pressing in, but a chemical one where the nucleus pulposus, remember, it's oily, highly viscous, ooey gooey material, and the dura doesn't like it. And next to the dura are the sacral nerve roots, so that's where they get irritated. All right, so these are more examples of annular tears. Barry showed this. Does the abnormality cause the symptoms? Well, that's a key point. If you're going to have an abnormal MRI, okay, well, 25% of you will have the abnormal MRI, but we're not operating on you unless we are sure it's causing symptoms. So we have the neurogenital tests. We've talked about those. The 3 of them are hot, cold, and vibration of the genitals, the penis, the perineum, the pudendal nerve region. We put people prone and we measure their vibration of the buttocks, thighs, and calves area. That gives us the sciatic contribution. And then we do a reflex, like a reflex of the arm that contracts or knees. You touch the penis, that activates sensory information to the conus medullaris, turns into motor information to the pelvic floor. So you get this muscle contraction when you activate the penis, 45 milliseconds, 1/1000th of a second. It's a pretty efficient neurologic system. And then the final thing are targeted injections. So this is somebody who has an annular tear here. You can see the HIZ, you can see the HIZ here. Point. You can't see the lesion in one view. This is sagittal, this is axial. You have to see it in both images. That's really, really important. And the images have to be in a reasonably good quality. So a Tesla 3 MRI, not 1.5 or lower. And they have to be relatively recent. They can't be 5 years ago. You don't want to operate on somebody with an old MRI. You got to get something at least a year within the system. So there is the annular tear. That's the HIZ there. If you put bupivacaine right in here and the symptoms go away, they fill out a form. We have developed this form. I have had substantial relief from the orgasmic symptoms since the procedure. I also turned off my InterStim for the procedure and haven't had to turn it on and back on. And 60% of the symptoms went away. That's really an impressive sort of result. And then I'm
going to remind you, Dr. Wilson, remind you that if you wind up working with a spine surgeon and working with a pain management doctor, if your patient tends to take medication to dull their dysesthesia, you're going to want to remind them not to take the medication on that day. You want the dysesthesia to be easy to be able to identify improvement with the injection.
You bring up a very important point, and that brought up another important point in my brain. These injections in the back are not NOT without risk. These injections in the back are very different than the neurogenital tests that we do, which are completely kind of pain-free and risk-free. Sticking a needle in the back, in our experience, in a good pain medicine specialist has like less than 1% chance of problem. But there are people who've had persistent pain, new onset sciatica, could have infection, etc. So you don't want to do this willy-nilly. You want to do this when you have the correct patient and you've done all the appropriate testing. But this is a Likert scale. It's the PGII is Patient Global Impression of Improvement. Very much better, very much worse. Much better, much worse. A little better, a little worse. And then the tweener where there's no change. So this person had 60% reduction of symptoms. He didn't need his InterStim, and he was much better. So he had a really positive response to that injection. So that strongly suggests that surgery would do well. Now, if you have a significant diagnostic...
That slide was actually his response after surgery. We don't do the PGII after the injection. The PGII was done after he did the surgery.
No, that's incorrect, by the way. PGII is done as the measure of whether TFVSI works or not. Every patient fills out a PGII with the target injection. But as you correctly said, we do measure this post-op so we have a sense of improvement long-term. So this is Dr. Kim doing his magic. So he basically works with, like a robotic surgeon works in the prostate, and he puts there's no scalpel involved. It's a trocar that goes in place. He's now doing what's called a chromatodiscogram, and he's injecting, well, no, he's past that stage. He's ronzuring out the nucleus pulposus fragments within the epidural space, and he uses a laser to do that also. But you can see it's all done through non-invasive or minimally invasive. It's called lumbar endoscopic spine surgery. The acronym is LESS, and our paper that we just submitted to JSM is less in the presence of annular tear-induced sacroradiculopathy causing the sexual dysfunction of PGAD. So that takes about 2 hours to do that. Patients go home the same day. So in summary, spinal abnormalities can cause sexual dysfunction. Who would have known? You would think sexual dysfunctions, they're only caused by local pathology, either in pudendal or genital area. And that diagnostic injections improve surgical results, but you got to do some functional neurologic tests to get to the diagnostic injections, because diagnostic injections do carry some risk. And simple annular tears with minor mechanical impact on the dura, but major chemical irritation of the dura, therefore chemical irritation of the sacrospinal nerve roots, causing sacral a radiculopathy, can cause sexual dysfunction, and we have proven that beyond a shadow of a doubt by the evidence of people getting better after the surgery. And way more work is needed and expanded so that many people who deal with urology and weird pains and weird dysesthesias in buttocks, thighs, calves, as well as penis, genitals. Barry brought out prostate, epididymis, these chronic prostatitis, interstitial cystitis things may actually, in a percentage of them, come from the lower back area. So I want to thank you on behalf of Rachel, myself, Barry, and Dr. Kim for this.
Erwin, can I add something to what you said? Just
Please.
You made a comment about when that that Joel was used to doing surgery for lower back complaints. And then, but when he started asking those patients if they have any genital problems, it turned out that about 20% said that they do.
That's true. It works the backwards too. So we work on genital stuff, and some of them have sciatic pathology.
Right.
He
Yeah.
works on sciatic pathology, but nobody asks about their sexual problems. If you did, which is one of our fellows did the research, soon to be published, that a reasonable percentage of sciatic, if you ask them, have sexual dysfunctions and dysesthesias and things like that. Excellent point, Barry.
Can you stop your screen share, please?
I can do that right now.
Thank you. So we have just a few minutes left. Nobody wrote any questions, but we've had some comments throughout. I just want to throw this out to our speakers. So we've seen patients with annular tears and patients with Tarlov cysts. Is there any definitive separation that one of those causes certain kinds of sexual health problems and another causes different kinds of sexual health problems?
We are doing exactly that study right now. So we have a symptom questionnaire that we're sending to people with the PGAD, persistent genital arousal disorder, GPD, and asking for their symptoms and for their MRIs to see whether they have Tarlov cyst or a herniated disc, and correlate that with their symptoms.
So
why would it be any different? It's just irritation of the nerve root. Why would one be different than another? The reason I say that is that we have a collection of a thing called a facet cyst, which is another version. It's not a Tarlov cyst. It's not an aneurysm. It's a collection of fluid from the joint space that becomes a cyst. But that also causes sexual dysfunction. And we have people with spinal stenosis with sexual dysfunction. So to me, it's just whatever irritates the nerve can cause a sexual dysfunction.
Well, it may be the localization of the irritation, because the Tarlov cyst forms on just one nerve, and whereas the disc affects all three. So so it may be more selective. There might be a larger group of symptoms with a disc problem than with a Tarlov cyst problem, and it may depend on the size of the Tarlov cyst, because then if it's really large, then it could affect the other fibers, the other nerve fibers. But basically, the Tarlov cyst occurs on one nerve root.
I think the bottom line is there's still so much we need to learn, and we're just a few people that are trying to move this field forward. But for all of you who are watching today, and for people who listen later on to the recording, there's so much more information needed. We hope that some of you are inspired today to think out of the box, to think about causes of genital dysesthesia, not necessarily being in the genitals. That's the purpose of our discussion. And if anybody wants to learn more about what we're doing, feel free to reach out to us, or you can, or attend SMSNA. We all have presentations at the SMSNA ISSM meeting in Miami. I look forward to seeing a lot of you there. But don't be afraid to ask. Don't be afraid to pursue new concepts, whether it's meeting with a pain management doctor near you after you've done neurogenital testing to get the injection, to work with a spine doctor near you that might be able to help. I mean, it's important that that we grow what we're doing in sexual medicine. Yes.
I want to say one last comment. I had a patient with SRPEs, sleep-related painful erections. And he goes on and on. He failed ketoconazole. He failed the usual treatments. And the urologist put in a penile implant to damage the tissue so he wouldn't have SRPEs. And guess what happened? He still had SRPEs despite the penile implant. It was much worse because now there was way more irritation. And we ended up getting an MRI, and he had an annular tear. And we believe that the SRPE has really had nothing to do, and he has phantom pain now with the penile implant in place. So I think that the message is, when Barry came out in 2012 with his paper, and I thought he was completely in left field, well, now he's come into, his world has come into ours, and it's so true. Think cauda equina when you don't know what's going on. I'm very impressed by the amount of pathology that exists there that reflects in the genital pelvic area, which is our world. We own the cauda equina, by the way.
Thank you so much to Dr. Goldstein, Dr. Karmasarek. Thank you to all of you who have stayed on throughout this webinar. I am so proud that there are so many members of our society who want to learn more, who want to expand this world. So with that, I wish you all a pleasant evening. It's 80 degrees in San Diego. Some of you are in places where it's cold, but be well, and goodbye.
Thank you, everybody.
Thank you. Thank you, Sue and Erwin.
Thank you, Barry. We love you.
I love you. Really, thank